Welcome you to the genetic disorders in medicine. So we'll start with Marfan syndrome, where the defect is in the FBN1 or the 2 gene. It is an autosomal dominant inheritance pattern on chromosome number 15. So what happens? How will they present with? They will be presenting as a tall, lanky build with chest wall deformities. The fleets will be flat. The spine will they can have scoliosis. They can have a mitral valve prolapse, and aortic dissection risk is present. The problem is that it will code for a fibrillin glycoprotein that forms the elastin sheath around it. So that is the problem in Marfan syndrome. Ehlers-Danlos may be associated with berry aneurysms because that is a collagen defect. But while in Marfan syndrome, the defect is in the fibrillin glycoprotein. What about the FMR1 and FXN? FMR1, the problem will result in a fragile X syndrome. The fragile X syndrome is an X-linked disorder because of the trinucleotide repeats. What is a trinucleotide that is repeating? It is the CGG trinucleotide repeating. When this repeat happens, it will result in gene hypermethylation and silencing. Because of this, they have a typical clinical presentation of large everted ears, long narrow chin, macroorchidism, and intellectual disability. The similar to FMR1 gene, the other gene is FXN, which can result in an X-linked condition, but this is Friedreich's ataxia. Here, the trinucleotide repeat is GAA. So what will they present with? They will present with obviously ataxia, and in addition to it, cardiomyopathy, scoliosis, and decreased reflexes are also seen. What happens in G6PD deficiency? G6PD deficiency is an X-linked recessive. We want G6PD to protect the cells from oxidation. So the cells cannot be protected when there is a G6PD deficiency, and they will be presenting with hemolysis as well as jaundice following the drug oxidizing drugs or viral illness. What drugs can present G6PD? They can be triggered by sulfa drugs, dapsone, as well as primaquine. So because of all these drugs, the hemolysis will happen. So because of hemolysis, the hemoglobin which is present inside the RBCs get denatured, and the denatured hemoglobin is known as Heinz bodies. These RBCs which contain the denatured hemoglobin or the Heinz bodies will be phagocytosed, or the spleen will try to remove it, resulting in white cells also known as degmacytes. What about the hereditary hemochromatosis? The abnormal gene is HFE, and this is the condition which is due to which is an autosomal recessive disorder on chromosome number 6. The only way to control iron in our body is by intestinal iron absorption. So whatever iron is present in the intestine cannot be absorbed fully by the body. Whatever is needed will be absorbed, and the remaining will be excreted. When that regulation is impaired, it will result in hereditary hemochromatosis. Body cannot excrete iron effectively. Therefore, the intestinal absorption is impaired. This will result in bronze diabetes, where because of excess of iron getting deposited in the pancreas, it will result in diabetes, and the excess of iron being present on the skin, they will have a bronze pigmentation. So it is collectively known as bronze diabetes. What about the hemochromatosis complications? The iron deposition in cardiac muscle will lead to cardiomyopathy and heart failure. Iron deposition in cartilage will lead to chondrocalcinosis. Iron deposition in the liver will result in hepatocellular carcinoma. How will we diagnose if the patient is suffering from uh, hemochromatosis? We need to check the ferritin levels. When that is more than 300 milligram per deciliter, then it is a clue for hemochromatosis. How will we treat them? So we need to reduce the iron overload by serial phlebotomy is the treatment. If you ask whether chelators can be used, chelators are not the effective treatment for hemochromatosis, but instead for a transfusional cirrhosis where the iron overload occurs because of repeated blood transfusion. In those cases, chelators can be used. What is Huntington's disease? The defective gene is HTT. This is an autosomal dominant disorder due to the CAG trinucleotide repeat expansion on chromosome number 4. The primary damage happens to the caudate nucleus. Thereby, they will be in Huntington's disease, they will be presenting with movement disorders. They will present with cognitive decline as well as chorioathetosis will be the presentation. The onset will be 30 to 40 years. But what is more characteristic is Huntington's disease shows anticipation. That means with each generation, the disease occurs much earlier. To be more clear, if the grandfather had the disease at 60 years, the father might have the disease at 50 and the son might have at 30 and the grandson might have at 20. So that is the anticipation, occurs much earlier with each generation. PKD 1 and 2. This will result in adult polycystic kidney disease. This is an autosomal dominant condition resulting in polycysts in the kidney. Why do we have cyst? What is the defective protein? The defective protein is a polycystin protein. This polycystin is a renal cilia. So when that cilia is abnormal, it is not able to clear the secretions and therefore it forms the cyst in this leading to polycystic kidney disease. So polycystin protein is abnormal and that is affecting the renal cilia. This can cause hypertension because the cysts will compress the renal vasculature resulting in hypertension. They can even present with beryaneurysm, that is an associated feature in adult polycystic kidney disease. The question that is concentrated with respect to this is that serial BP monitoring. When you suspect someone with subarachnoid hemorrhage, the preferred method for screening is serial BP monitoring. Why MR angiography is not done? MR angiography is indicated only if there is a family history of subarachnoid hemorrhage. Only then MR angiography can be done and they can be screened. If subarachnoid hemorrhage has not occurred in the family, then serial BP testing is the indicated screening. In adult polycystic kidney disease, they are associated with liver cysts. What about a pediatric polycystic kidney disease? This is then autosomal recessive pattern. That is the difference between adult and a pediatric kidney disease, and occurring in a child. So this will be accompanying hepatic fibrosis. So both adult will present with hepatic cysts and the pediatric autosomal recessive polycystic kidney disease will present with hepatic fibrosis. So with this, we have come to the end of our genetic diseases. All the best to the exams that you are appearing. Have a good day.